Okay, I have that we're 3 after, so out of respect for your time and our presenters' time, let's go ahead and get started. Welcome to today's Lunch and Learn. We are hoping to make this an informative series for you and look forward to spending some time today on hereditary cancers. Before we get started, I'll introduce myself and do a little bit of housekeeping, and then I will turn it over to our fantastic speaker today. My name is Alex Huffman. I'm the Assistant Director of Support Services. I did want to make sure you're aware that we are recording this session, and we'll also be able to email this to you so that you can review it or have it as an archive should you want to reference it. If you would submit your questions in the chat, you can do that at any point throughout the presentation, and we will circle back to those at the end of the presentation in a more situated question and answer time. We also want to note that this topic today especially brings up a lot of personal questions, and while we're not able to answer those in this informative setting, we highly recommend you reach out to your healthcare provider. If you're working with a genetic counselor and hear something, reaching out directly to that person or asking for a referral to genetic counseling so that you can get the most direct answer to your personal questions. So in the spirit of moving forward, let's go ahead and get started. We are presenting today on hereditary cancers as part of the 13th anniversary of National Hereditary Cancer Awareness Week. So this special week has existed for 13 years since Congress made this dedicated week. This week intends to acknowledge those with a genetic mutation who are at increased risk of cancer, as well as their families. We know that 90% of the millions of people with a genetic mutation are not aware of their risk. And we hope that today is an informative session where you'll receive more information and get a better understanding of the elements of hereditary cancers so that you can know your own increased risk potentially and spread awareness in your community. So now I'm going to turn it over to one of my dear colleagues, Sara. Sara Pirzadeh-Miller is a certified genetic counselor and associate director of our cancer genetics program here at UT Southwestern. She leads 19 genetic counselors who provide hereditary cancer risk assessment in 5 hospital systems in the North Texas area. She's also the incoming president-elect for the National Society of Genetic Counselors, which is a huge accomplishment. Her research interests include genetic counseling, workforce efficiency, service delivery models, and population screening. So Sara, I turn it over to you formally.
Thank you so much, Alex, for that introduction and really setting a great stage for our conversation today. So happy to be here with all of you, and thank you again for taking your time today to learn about a topic near and dear to my, and I hope really educational for all of you. I'm going to share my some slides to speak through here. Give me one moment. And Alex, can you confirm that you can see that in a second here? Okay, here we go.
Can now.
Perfect. Okay, so again, so excited to be here with you all today. And as the leader of our cancer genetics team here at the Simmons Cancer Center, where I've been here now for over 16 years, it has just been so phenomenal to watch the growth in this space and to continue to work with so many patients coming through the cancer center and in our community that really need this critical information that helps individuals really understand their levels of cancer risk, what they can do with that information, and how that can help their families. And we'll be talking a lot about that today here in our time together. So let me advance my slide here. Here we go. So just a little overview of what we'll talk about in our time together today. Kind of who are genetic counselors. Some of you may already know, some of you, this may be a new topic. So I just wanted to define that, as well as, of course, genetic counseling and testing, some kind of overarching themes and things we think about with hereditary cancer syndrome. So very appropriate for this week in the United States. And some hot topics in our space that I think many of you have probably intersected with, heard about, whether it's kind of in the media or maybe if anyone has been walking in a cancer journey, some things there that might be really, applicable to things that you've talked about. So we'll walk through those things today and look forward to your questions later. So I always love to start with some fun facts, and this is pretty humbling, to be honest. Thinking about how much DNA you share with your best friend, your fellow humans, That, not shockingly, is most. It's 99.9% of your genetic code is shared with any of us here. We all are very, very, very similar, and those minor differences make us as diverse as we are, which is what continues to amaze me about genetics. But how much DNA do you share with a banana? This is going to, I think, be a humbling piece of information. 40% of your DNA you share with a banana. So I hope those of you at home are laughing and chuckling to yourselves, because it is, again, it's quite humbling if you thought you were really that different from a piece of fruit. And with E. coli, with a common bacteria, you share 7% of your genetic code with a common bacteria, which was more than I ever thought. So nice way to kind of set the stage for thinking about these minor variations in genetics and how impactful they are. And like we just talked about, genetics is in the media. We lovingly refer to the Angelina Jolie effect that really came into effect 10 years ago. In fact, exactly 10 years ago this summer, where she published an op-ed in the New York Times about her decisions that she made for risk reduction for breast and ovarian cancer due to her known BRCA1 mutation that she discovered related to her family history of similar cancers. So that sparked a national and international conversation about this space, and I think just continued to snowball from there. Another great example is Beyonce, Queen Bee, her dad, very vocal about his breast cancer journey and his BRCA2 mutation. That really was the driver of that. Beyonce has not ever been so public about her, what's happening in her world with those things, but her father was very vocal about that. So all these things that are raising awareness in this space over the last several years. So that kind of brings us to a genetic counselor like me would easily be talking to any of these folks, and I hope that they did, because they could have really used that professional. And so just to level set, genetic counselors like myself, we do a lot of things. We provide information about genetics in many different spaces. And you can see that here on this slide, I named just a few of the specialty spaces that genetic counselors routinely are very involved in. Discussing benefits, risks, and limitations of genetic testing. That's what we do quite a bit in our pre-test genetic counseling sessions that I'll talk a little bit more about. Really helping patients understand what could this look like for you? What could this mean for you and your family? And what maybe you can't understand from a test like this. Interpreting genetic test results, helping patients and individuals make decisions about really important, kind of healthcare journeys that folks really go on when they learn this type of risk information and what they can do to really optimize their healthcare. And of course, providing support to everyone. Alex is one of these support individuals, thinking about support in those ways. And in the genetic space, we provide a lot of support when it comes to everything surrounding the genetic testing process, dissemination of information. You can very much imagine in your own families, if you think about yourself, you think about if you have children, if you have siblings, we all have parents in some form or fashion, and extended relatives. This affects everyone, and those relationships, lots of things to think about when it comes to that information. So that's part of why counselor is part of our name, is we have that acute psychological and psychosocial training so that we can also interact with, colleagues like Alex, like social workers and other of our, clinical psychology colleagues and others that can really help our patients work through some different things that may arise with this information. Here's what we don't do as genetic counselors. We do not clone people. No. This is not what we do. We do not create designer babies. No, this is also not what we do. So I like to just, it's a little tongue in cheek, but I have had those questions come up of, well, I heard this and that. Well, let's be clear. No, we do not do eugenics. We do not do these things. But what we do all the time are a lot of other things. And there are many roles that we play. I like to just kind of think about our role. Yes, we are scientists for sure, by definition. We are also counselors by definition in our space, of course, in a very acute setting. But we're also detectives. We're translators of very complex information. We're advocates for our patients. We're teachers of very complex information as well to many audiences, such as yourselves, such as our patients, such as other healthcare providers, and other allied health professionals. And so that's really what still makes me so excited about what I do every day, even this far into my career, is that we just have so many skills to make happen in many different ways and apply in many different settings. And every patient's a different person. And so that's why I still love what I do every day with patients. We'll now transition a bit into some of these genetic cancer and counseling and testing concepts to kind of give you a sense. So in a cancer center like ours, we see many patients diagnosed with a variety of cancers. And the question we always get, like many of my colleagues here on this call will understand, is why did this happen? What are the reasons? What happened here? And so I like to just kind of think about it. You could kind of think about it like Google Maps, if you will, like a really wide view of why cancer can happen. A small chunk of that is true genetic inherited risk factors that cause elevated risk for cancer. 5 to 10% of all cancers, you can use that ballpark, is truly from a genetic mutation running through a family causing that. The rest of it is either maybe a little bit of genetics or not at all. So 60% of cancers are truly not related to genetics whatsoever. They're common environmental factors, common age-related factors, exposure-related factors, different things that we won't focus on today, but that we talk about in genetic counseling sessions, because we have to think about all the risks for why cancers can happen. And again, genetics is a part of that, but there's a lot of other things that are a part of that too. There's also kind of a mixture of hereditary and non-hereditary factors in that little area that you see called multifactorial. And that's quite a bit of cancer. You know, when you see a clustering of cancer in a family, sometimes more than you would expect by population statistics, we think that in some of those families, there's some minor genetic factors, some common shared external factors that can manifest in a family to cause more cancer incidence than we would expect to see based on population data. And so we don't have a beautiful test for that, but it's at least it's a construct to think about in some families why we see those things. But today we're going to focus on that hereditary 5 to 10% piece, because for those individuals, it's incredibly important. What are some common guideposts, if you will, for hereditary cancer? When are we concerned about that? And this is just a nice, again, a guidepost list. I say that very specifically because this is not a definition. These line items are, okay, if I have young breast cancer when I'm 40, or if I have many relatives and many generations on one side of my family or the other, mom's and dad's side, you got to think about both of them. If I have, a close relative with kind of mirror image, like bilateral breast cancer in both breasts at the same time or at different times. Cancers that can run together under a gene, which that's part of our detective work. Some genes like BRCA1 and 2, we see a lot of breast and ovarian cancer in those families, just as one example. And some, rare cancers. So some of these kind of unique features or combinations thereof are times when we really want to think about hereditary cancer. And I really want to say, if your healthcare provider hasn't brought up your family history, bring it up to them. That's sometimes we have many healthcare providers that this is much more increasingly on the radar. Some are not. There's just a lot of things going on in their world. And so please do bring up your family history of cancer or other medical conditions, with the appropriate healthcare provider if they haven't. So just, please feel free to be proactive in that way. So what happens in a genetic counseling visit in the cancer space? A lot of things happen in a short period of time. So our visits in our practice are generally about 45 minutes or less, where we're trying to really assimilate a lot of information pretty quickly. We're gathering personal and family medical information, especially as it relates to cancer, and really using that to then personalize, what does that look like for the person in front of me? With all this history or their own history in mind, let's talk about hereditary cancer risk. Let's talk about the ins and outs of genetic testing, what that can mean for you and your family. How does it work? How do we do it? What are the logistics of that? How does insurance play in? We have all of those conversations. I talked earlier about benefits, risks, and limitations of genetic testing. That's a part of the informed consent process. So we talk about that together. And then if indicated, which for most of our patients that do end up going forward after the visit with either a blood draw or a saliva collection, we see a lot of patients through Tella Health, as I'll talk about in a second. And so we can have saliva collection kits sent to the home of the person we're speaking with. And then they can send that back from the convenience of their own space. Or if we're here in person, we'll be sending you down to the lab for a blood draw, if that makes sense. And then we get that sent off. And then usually within about 2 weeks, our team will be calling that patient with whatever the test results are. So in our practice, we do a results disclosure over the telephone. It's not a separate visit. And we have that conversation about whatever's going on. And then, of course, if the patient has a positive test result, which would mean, okay, I have a gene mutation that causes elevated cancer risks, whatever they may be. We're talking about that, and then and what do we do with that information from here? We are thinking about screenings or other risk reduction measures, and who needs to be involved in that conversation with that person, other specialists and things of that nature. We'll talk about that. We'll talk about family. What does a family need to know? What do they need to be thinking about? Providing tools for those individuals with positive test results to get that out to their relatives. We talk about that as well. And then, as I'll talk about in a couple of minutes, we this year opened actually a longitudinal clinic for patients with a positive test result that means they have elevated cancer risks, to help them manage that really from here on out with annual visits with us in our Genetic Cancer Prevention Clinic, or GCPC, which I'll talk a little bit more about in a second. We're really excited to have that clinic offering to really help our patients. I mentioned earlier that we can do telehealth in different ways. And I always tell people that was the silver lining of the COVID cloud, was the fact that telehealth was able to very promptly and very robustly, able to be used as a service delivery model. And for genetic counseling, it's perfect because we don't have an in-person component that is necessary to be in person. We can do in-person's great. We can do video. And with some populations, we also do the telephone, especially with our county hospital populations where we serve. That helps lower some barriers to care. With sometimes with video bandwidth, that can be tough in some areas. But with UT Southwestern at Simmons Cancer Center, when we receive a patient calls us or we receive a referral, we offer every patient either a video visit or an in-person visit at one of our in-person sites, Dallas or Fort Worth at this point. And then go from there. So we can meet patients wherever they are. And the great thing is with telehealth, if you're in the state of Texas at the time of the visit, we can see you. So we do have the state boundary piece, but hey, Texas is a lot of real estate. So as long as you're sitting in the boundary somewhere, we can see you via telehealth. And that really expands access, of course, for lots of folks that we can see inside and outside of our catchment area. In genetic counseling, we talk a lot about testing options. And so this is a very general schematic of the types of tests that you could hear about. And I like to just kind of give this overview. These days, especially since the Angelina Jolie effect, that was actually the same year that panel testing became clinically available very routinely. So when I say panel testing, that means multiple genes that we can look at once. And we can typically do that within about 2 to 3 weeks. And so cost and time spent in the diagnostic odyssey really came down quite a bit upon the advent of this technology in the last decade. We've really robustly been offering panels, like really talking to the patient about what they need and what makes sense, and especially based on their personal and family history. But in our practice, we very routinely run very large, anywhere from 40 to 80 gene panels in the cancer space. So we're looking at cancer risk related information only in our practice. Some practices do bigger tests, or some practices do some different things. But when you hear panel testing, that's what that means. Many genes at once, like you see there on the slide. There's also single gene tests, which mean that we're looking at one gene for a particular reason. Maybe there's a very specific clinical picture that tells us, oh, really, this gene's the thing we're concerned about. We're really not concerned about other genes. So when you hear about a single gene test, that could be the situation. And also single site, which typically means that we're looking for one place in a gene, that something has been identified mutation-wise in a family where we know, oh, there's a mutation in the BRCA1 gene that we need to look at for this particular person. That doesn't mean you can't also do a panel test in that case, but when you hear about a single site test, it's typically in the context of a known family member has a mutation and you're at risk for that, and that's the testing that's very much indicated in that moment at the very least. So that kind of gives you a little bit of perspective, types of tests. There's also several limitations and kind of things to think about in the world of genetic testing. Very much that if anyone tells you you do not have any genetic reason for cancer risk after a negative genetic test, it irks me a bit when I hear that, because we don't know everything. And I tell patients this all the time. We don't know every single gene in the cancer risk space. We don't know every single gene in the medical realm of things. So I don't think anyone can ever say with a negative genetic test in 2023 that you have nothing genetic going on. So I always like to plant that seed. Now, with testing we can do these days, if we look at all these genes and they look fine, I can routinely tell a patient, I feel very reassured that the likelihood of you having a cancer risk related genetic issue is very low at this point, but I'll never say zero because we don't know everything, right? That's an important concept. Also, there is the concept of variants of uncertain significance, or VUS. And what that essentially means is when the lab finds a genetic difference that we don't quite know what it means yet. Does it mean, oh, this gene is broken and there's cancer risks and it's a positive test result? Or does it mean, oh, wait, that's just makes us different people? We have lots of genetic changes in our genetic code. That's what makes us different. The 99.9% we talked about earlier, that 0.1 is all these different changes that I'm talking about that have nothing to do with impacting your medical health. But sometimes a different change falls in a place where it causes a gene not to work the way it's supposed to and causes disease risk or cancer risk. In this uncertain space, we're just awaiting more information from the research and the data in the laboratories to understand what this means. And eventually we'll get an amended result to say, oh, that thing that was uncertain in 2023, we now know, oh, yeah, this is an issue, or no, not a big deal. It's negative. And so when we get that, we get back in touch with the patient in the best way that we can to let them know. Now, I do have reassuring data to say that over 90% of the time, uncertain variants end up being reclassified to negative or normal. So most of the time, uncertain variants are not a big deal, but when they do get upgraded, that's definitely a conversation we need to follow up on. Negative results are truly negative if there has been a mutation identified in the family already. So a negative test result, I was just saying this, it's generally good news, generally for most people. It just means that those genes look good and I'm not worried about them. But again, could there be something found in another family member that we didn't test? There's a lot of things to think about with a negative test result and the interpretation of that. So we talk about that with our patients. And of course, that genetic tests like this do not diagnose cancer. They don't tell you you're going to have cancer. They don't tell you that you're going to with 100% certainty. What this genetic test result says, if it's positive, is there is elevated risk for certain cancers in that person's lifetime. And then that's the conversation that we have, is to define what that means. But we always talk about in genetic counseling that the genetic test itself does not tell you you have cancer and does not tell you that you're absolutely going to have cancer. It's all about risks and numbers. When we think about testing and strategy of who is tested in a family, there's a lot of things to think about, but we test routinely lots of folks that have never had cancer, and that is totally fine, absolutely good. But what we talk about is, well, if I'm talking about myself and my mom had breast cancer at 40, I've never had cancer, she's never been tested before. What I would tell my patient in that situation is, well, hey, is mom living? Has mom been talked to about testing? Because if she's tested and all looks good with her, then I feel much better about the person I'm looking at in front of me that has not had cancer. We're worried about mom and her history. If mom doesn't have anything going on that we can find, then my patient still needs to be followed closely from a breast cancer perspective, but not so likely to have a big genetic factor related to it. So we have those conversations about, in a family, where should testing begin? But hey, sometimes those people aren't available. Sometimes they're deceased. Sometimes we're not in contact or they don't want to. So we talk to patients. What's really important is that interpretation of a genetic test once we have it back, because a negative in one person may not mean the same thing as a negative in another person. And that's where genetic counselors really come into play, is really helping patients understand, what does this result mean in the context of your particular situation? Of course, genetic testing affects the whole family. Genetics is a family science. That's why we love it. That's why we do what we do. And I so enjoy that element of it. The conversations are not always easy. And there are a lot of tough roads and things to talk about. But in the end, in cancer genetics, what the promise of it is if we can identify what's happening in a family, then others can be tested, hopefully before there's ever a cancer, so that they can be on the prevention journey before anything ever happens, right? So that's what the beauty of this is, actionable information much of the time that we can do something with for families to help optimize their healthcare. Common frequently asked questions that I get and that any of us genetic counselors get about cancer genetics. First of all, will my insurance cover genetic counseling and testing? We talk about that in the visit, but generally speaking, you can think yes if you meet certain national guidelines, which I was talking about those guideposts, that type of thing. There's a National Comprehensive Cancer Network, or NCCN. That's the gold standard, kind of national group that UT Southwestern is a very proud member of. And we look at that and we talk to patients about, well, in this particular situation, do you meet these guidelines? How does that work with insurance? And we have some of those conversations, but generally, yes, in those situations. I still get the question a lot about genetic discrimination. So I like to highlight that the question being, will my insurance or my employer use genetic information that tells me I have risk for a condition or a cancer? Can they use that against me, essentially? Like, will they not hire me? Will they raise my deductibles? And the general answer is no. The general answer is met with no because of the GINA law, which I spell out here, the Genetic Information Non-Discrimination Act. That's been in place for over 10 years, 13, 14 years now. And there's some nuances to it that you can read more about, but the general idea is that employers and healthcare coverage insurance providers cannot use risk essentially as a pre-existing condition. That's the general idea. So now again, there's some caveats and some things that would take a whole other hour to talk about that you can read more about, but I think generally puts a lot of people at ease saying, hey, I can go get this information without being worried about these types of things. Also, I've already had cancer. What else can genetic testing tell me? A lot, actually. So at the cancer center, I routinely talk to patients that have had cancer, maybe now or in the past, and are survivors. And the question is like, well, I've had cancer. Like, I've done this already. Like, what genetic testing, what else can that tell me? Well, unfortunately, with genes, they're an equal opportunity player when it comes to, hey, I don't just sit in one spot, I sit everywhere, right? So there are typically 2 or more cancer risks that are elevated for somebody who has a hereditary cancer syndrome or elevated risks. So we want to talk about, well, what else, if you have something like that, what else is going on in terms of risk, and how can we help you go along that early detection and prevention journey? Could genetic test results impact my kids? Yes, is the short answer, because it's genetics. However, there's a lot to talk about when it comes to, okay, how old are your kids? Would this information impact them as kids, or is it more of an adult onset condition? Most of the things in the world of cancer genetics are adult onset risks. And so we talk a lot about kids, hey, let's get them to 18 or 20, and then thinking about as they are legally adults and can make those informed consent decisions, what makes sense for them, and they can make those decisions and have those conversations. But, we talk to patients all the time about these types of issues, and we look at their particular families and structures and histories to help them navigate some of those conversations. And of course, I've heard genetic testing is so expensive, I couldn't afford it if my insurance didn't cover the cost. So about 10 years ago, I couldn't say this, but in the last few years, several of the major genetic testing third-party laboratories, they routinely now have a patient pay flat rate of $250 for as many genes as we want to look at. So if insurance is not jiving with covering the cost, and it looks like that cost is going to be over that amount, then patients have the opportunity to make that switch before it's processed through insurance. We talk about patients with that in the genetic counseling session, so we can get into the nuances there. But the good news is that people aren't afraid of thousands of dollars in cost if insurance doesn't cover it. So that's a really important access point that's been huge at the UT Southwestern, in our population, because $250 is relatively palatable for many, not for everyone, but for some. And so at least it's a point that opens access for some folks. Now we're going to jump into a little bit more on the hereditary cancer syndrome front. So this just kind of is orienting us to, there's more than I mentioned earlier. We test 40 to 80 plus genes at a time. So definitely 50 plus genes related to hereditary cancer risks. All of them have different cancer patterns of risk, different levels of risk for those cancers. And then the management recommendations that go along with it are, optimized for whatever that risk level is. So we'll talk a little bit more about that, but that kind of sets the stage for like, what are some of these conversations that we're having, when we think about hereditary cancer syndromes. So focusing just on a very general world of hereditary breast cancer risk, which this is a big world. You can see here just on the slide that there are several genes these days that we think about when it comes to elevated breast cancer risk. You've heard of a couple probably for sure in the BRCA1 and 2 genes. Many have at this point. PALB2 is another one on the scene that causes 50+% risk in the lifetime for breast cancer in those who identify as women. And then there's several other genes that you can see there on the kind of, I say lower end, they're still elevated risk, but they're not 50+. If you think about any woman's risk for breast cancer, I'll say female breast cancer, 13%. So 1 in 8 women, that's kind of the general statistic. Moderate risk is typically identified as 20% or more in the lifetime. And then really high risk is like 40, 50+%. So that's kind of how we categorize these. All of these also relate to other cancer risks, but we're just kind of thinking about breast cancer risk management as just kind of a general topic right now. And so what are the considerations that we talk about? There's definite options that we talk about for management, depending on a lot of considerations. You can see here, we talk about, okay, how old is that person now? Risk level of related to the gene in question. What's their family history that we already know about? What's their medical history that's going to help that person that has to make decisions for themselves based on whatever else they have going on? But in general, the types of interventions we're talking about are either surveillance, like a high-risk surveillance protocol, which is essentially breast MRI and mammography, typically every 6 months. We try to stagger that, so 2 times a year with kind of the latest and greatest technology, so we can look at the breast very closely, very consistently. That also sometimes is paired, if it's appropriate, with maybe a medication-based risk reduction agent. Some people might have heard of tamoxifen on this call, but those conversations for medicine-based risk reduction are a conversation that some have. There's also the risk reducing or prophylactic surgery conversation, especially for those that are at very elevated risk for breast cancer, like the BRCA1, BRCA2, the PALB2. Those are routinely having the conversation about, well, does a risk reducing surgery make sense? Removing the breast tissue before there's ever a cancer. This may be a conversation at the time of breast cancer diagnosis where someone already has a breast cancer and they're thinking about, well, is my other side, while unaffected right now, what does that look like for the future? Do we need to be thinking about different management? Or somebody's never had cancer, but they're at higher risk, which is called a pre-viver, which I have there on the slide. And actually Wednesday was National Pre-Vivers Day. As Alex talked about the hereditary Cancers Week, Wednesday was recognition of our pre-viver population, because they're a big population. Lots of folks with cancer risk that has not manifested, but they have risk, but they're dealing with management now. And so thinking about, for some of those folks, thinking about a double mastectomy as a preventative measure is a conversation. So we're talking a lot about these different things with the genes that we just mentioned on the other slide. Now, flipping the script a bit to colon cancer, hereditary colon cancer risk, there's kind of a grouping here too, you can see. So there's a few genes that put folks at very high risk for colon cancer. There's several that put folks at elevated but more moderate risks. And so that's, again, the management conversation that I'll talk about on the next slide very much relates to whatever those risks look like. But you can see in the top arrow, the Lynch syndrome, which is the most common hereditary cancer syndrome overall. So 1 in 270 people carry a Lynch syndrome mutation. And as Alex said, most don't know it. And so that campaign of education, and this is why we do these things, is to make sure people are thinking about these things. Also, this gene called APC, which causes a polyposis condition, which means these people make lots of polyps in their colon just by nature because they have this gene mutation. And if those polyps can't be controlled, by just removing them very frequently, then there's some other management conversations that need to happen. So we have lots of conversations there. And in our more moderate risk population, we're talking a lot about, okay, what do those cancer risks look like? Risk number wise, and what do we do with that information? And there's a whole alphabet soup here to take in. But those are some of the folks that, are dealing with those cancer risks. And what are we talking about with those folks? So just like in the breast world, we were talking about, surveillance screening versus maybe a surgical intervention. Similar here. I would say for most of these individuals, we're talking more about surveillance. In a small pocket of individuals, we are talking about a preventative surgery, especially in our very severe polyposis folks, the ones that just make thousands of polyps and they cannot be controlled by just removing the polyps every year. That's where we're talking about a preventative surgery, which is no walk in the park. None of this is. But again, in the colon space, most of the time it's starting at an earlier age with very frequent colonoscopy, colon screening of some kind, but typically colonoscopy. And in some groups, there might be aspirin or medication to think about to help reduce numbers of polyps and that type of thing. But most of it is thinking earlier colonoscopy. When do we start that? How frequently do we need to be doing it? And family history comes into that, the gene comes into that, lots of considerations to think about for those folks as we think about optimizing their management. And then there's lots of other cancers. Obviously, we're just speaking about a few here today. But this just gives you, again, a flavor for the different cancer risks that we could identify. What are we talking about in terms of management? Ovarian cancer, we're definitely talking about a surgical intervention at some point when it's appropriate, because we know the screening for ovarian cancer, unfortunately, still not where it needs to be for really relying on that as a management mechanism. But for other cancer risks, we might be talking about different kinds of imaging, screening, like pancreatic cancer. We have an amazing pancreatic cancer prevention program at UT Southwestern, and they can, optimize that. We refer to them frequently so that they can talk to patients with high risk for pancreatic cancer and talk about the imaging that makes sense for them and talk about what interventions make sense for them. So that just kind of gives a little flavor. There's lots of things here. But really important things to keep in mind, the things we can control, right? And the things that we can do. So genetics, we can't control that. We can't change our gene. There's no vaccine yet to replace what's not there when a gene is broken. I hope we're going to get there. There's some promise coming. But what can we do from a healthy lifestyle choice perspective? Are we talking to our healthcare providers about what's going on with our own healthcare? Are we talking about signs or symptoms? If something hasn't gone away for 2 weeks and is getting worse, we need to be talking to our healthcare providers about that, right? That's just good medical advice just from the prevention perspective, right? Making sure that we're on top of that. And very important to remember that these recommendations and genetic information, all these things are going to evolve. So thinking about continued conversations with your healthcare provider about your family history, about your medical care and history, whatever's going on with you. All of that's important to make sure that you're just getting all the healthcare that you need. But in the genetic space, definitely something that continues to evolve. This brings me to talking about our genetic cancer prevention clinic very briefly. And I mentioned it a few slides earlier, talking about this is a place for us to be able to take care of folks that have a known gene mutation that causes elevated cancer risks of some kind. And we can follow them in our clinic longitudinally, meaning going forward for however long, right? And typically these are going to be annual visits. These individuals will see a genetic counselor, one of our 19 genetic counselors, a nurse practitioner or other healthcare provider, depending on the clinic, and a genetic nurse navigator. So we have a really focused team that's working with every person to really make sure they have their optimized plan. What are the cancer risks they need to follow up with? What's the surveillance or risk reduction that they need? Are they getting to the places they need to go in terms of other specialists that can handle those specific cancer risks and those conversations? And then a navigator who is so critical to this clinic that does an amazing job talking to the patient before and during and after and following the patient through so that they come to us again next year, ready to go, having more conversations, making sure they're getting everything that they need. So it's just a beautiful multidisciplinary model that really allows patients with so many things to think about in this space to feel like I'm covered. People have me. I'm feeling good about this center so that I can also feel like knowing that things will change too, and education and information, family conversations about the genetic issue at hand. We can continue those conversations with these patients and they can really feel confident that they've got the experts in place to really make sure that they are optimized from here on out, as long as they're, attending their appointments and doing the things that they need to do. So that's been fantastic to get started this year. We're only growing and we're really excited to continue to see patients. So I'm going to wrap today with a couple of hot topics in cancer genetics. And especially, I'll start here with this one, thinking about the types of genetic testing, and especially for those who have been on the cancer journey. This is something I educate patients on all the time is, I have a patient, let's say a patient with pancreatic cancer comes into genetics and says, you know what, I had genetic testing. My doctor said that they did some genetic testing on my tumor, and they're using that information to see if I'm eligible for certain clinical trials or certain chemotherapy regimens. And the confusion sometimes that happens is, well, I had genetic testing, quote unquote. So wait, didn't I already do everything? So the answer is there are different types of genetic testing. So, just to add a little layer of complexity here. So here on the screen, you see on the left, somatic mutations. On the right, you see germline mutations. And so what the difference is, the patient I just referred to with the pancreatic cancer who had the genetic testing on the tumor, That's somatic testing. So what that means is there's information from the unique genetic picture of the tumor that might help their doctors make decisions with them about, oh, this pancreatic cancer is showing this particular mutation that is unique. So maybe let's look for a clinical trial to see if there's something targeting that tumor, targeting that mutation specifically, that's going to offer personalized medicine for that patient. So when you hear personalized healthcare, personalized medicine, some of that conversation is related to this. Now, these are not heritable, generally speaking. So when we're doing a test on the tumor, that's generally not the information that I'm concerned that I'm going to pass on to my kids. This is related to the genetic complement, the genetic picture that is very unique to this cancer, to this tumor. Now, on the flip side, germline means inherited. So inherited, that's what we do as genetic counselors in our program, is we're facilitating and educating and helping folks with inherited or germline genetic testing. So these are mutations that are passed along in families from a parent to a child and so forth. And that these things don't always overlap. So if you have a genetic test on your tumor, that doesn't mean that's showing you everything that could have been inherited in your germline or in your inherited genetic material. So they are separate things that can overlap in a few cases, which could be a whole other lecture. But for the most part, for practical purposes, they're typically separate things. And so it's important if somebody's on that journey, if you're talking to your doctors or healthcare providers and you have any confusion about that, ask that question. Like, oh, you said I had genetic testing. Were we talking about my tumor? Were we talking about inherited things? Good to clarify, because we have that conversation a lot in cancer genetics. A great way to illustrate this in your real life or in a practical way is, okay, looking at this dog and their pigmentation, is that related to a germline inherited genetic event? Or is it something that's just in them, that's just not inherited, but just something that was a change in them, which would be a somatic event? Well, it's somatic because it's asymmetrical. It's a different color than the rest of the fur. And it's just a random patch. It's just like genetic differences in that one area. Again, this is just about color, right? This is not a medical condition. This is not a problem. This is just like this element that I'm describing in this way. So you can kind of think about it with like your dog. Like, do you see that in your dog? Well, a somatic, a non-inherited event. Okay, here's our cow friend. So we're looking at this cow and we're wondering about an event about this patterning on the face. Is it inherited or is it just based on their own genetic complement? And this one is actually inherited because it's symmetrical patterning on the face and the legs. So when you see things that are just happening in one spot, that's typically not something that's inherited. But if you see things that are symmetrical, I mentioned this earlier in the guideposts, right? Bilateral breast cancer, right? Mirror image. Then we think about inherited risk factors. In the image here is kind of a similar concept, right? Thinking about inherited reasons for coloration and patterns. So just kind of an interesting factoid that now you can look at cows and dogs and you can think about this type of information. And lastly, I wanted to address direct-to-consumer testing. And so this is a topic that we hear about all the time. And I only put a couple of brand names here just because I would say probably 90% of you have heard of these things, probably. Ancestry, 23andMe, these types of tests. These are just a couple of examples of a lot of direct-to-consumer tests. And this is where this is marketed to the consumer, not typically in going through your healthcare provider. This could be through television, through social media nowadays, through Amazon. I mean, it's all over the place. And this is generally at home, but to the point of your personal healthcare provider is not facilitating this for you. It's not always going through insurance. It's not like going through a clinic. It's just something that, like with ancestry testing, you can, spit in a tube and send it back to Ancestry and you can get an idea of your background, which is cool. I mean, cool, interesting, fun information in a lot of ways. Importantly, though, this information is not diagnostic and it's generally not immediately applicable to your medical or healthcare. Really importantly, and I'll just call out 23andMe because this is very specific to them. I've had patients come in with a report saying, hey, I had cancer genetic testing already. And we talk about that because there are a few limited genes that 23andMe is allowed to report on. In our practice, we're looking at 40 to 80 plus genes. That's not the same type of testing that's happening here. There are a few things they can test for clinically actionably. Like in the BRCA1 and 2 genes, there's a few mutations they can report on. But you still, even if you got that report and it says like, oh, I have a BRCA mutation, take that to your healthcare provider. You need to have that conversation. What does this mean for me and my family? But when you think about risk factors for diabetes, for heart disease, and so there are some genetic pieces of information on these tests that can say, oh, you might have a slightly increased risk based on this test, or you might have a slightly decreased risk. That one piece of information should not be used to guide your medical care in its entirety. You have to bring that to your healthcare provider to talk about what else is going on. What does my family history look like? What are my own issues going on? What's my own history? And integrate it all together to make an optimum healthcare plan. It should not just be driven on one direct-to-consumer test that was done, because that does not encapsulate the whole picture. And so just very generally, what you can learn about drug response. You know, does cilantro taste like soap to you, or does it taste like cilantro? That's a very specific genetic difference. That's very, very specific. And like for me, cilantro tastes fine. I have a friend, cilantro tastes like soap. I mean, that's a very distinct genetic trait. So just something kind of interesting. And of course, ancestry, genealogy, lots of cool things to learn. But however, a knowledgeable professional should be involved in the ordering and interpretation of tests. That's just a blanket statement. That's something I'm going to say as a healthcare provider in this space. But consumers, do what you do, but buyer beware. Know what you're getting into, read the fine print, make sure you're an educated consumer when you're thinking about this type of information, and bringing it to your healthcare provider, your genetic counselor, if it's genetics related, to talk about what this means for you and your family is always a good idea. So to finish up, some ways you can get in touch with us. If you want to read more about our program, there's our website, our phone and email, great ways to get in touch with any of us over time. This amazing team that I'm just absolutely thrilled to work with, that makes everything possible. All of our genetic counselors, assistants, scheduling team members, medical directors, the whole team. This was a pre-pandemic picture at an axe throwing place. We had so much fun. But that's what I have for today. I'm sure there's questions, but thank you all so much for your attention. And I look forward to seeing what y'all have to ask.
Thanks, Sara. This was super thorough and informative, and we already have some great questions. And I'll just send a reminder to the group to go ahead and add any more questions you have in now, and we'll definitely try to get to those in the next 10 minutes or so. So our first question is, should everyone get genetic testing, or just if you have a family history? Also, can you speak to what age is appropriate?
Yeah, that's a great question. So we get that a lot. Should everyone have genetic testing? I'll address that. I would say it's a personal decision. You know, it's definitely not prescribed for everyone. It's something you should talk to your healthcare provider about, talk to a genetic counselor about, but especially if you have family history of, you know, any of those guideposts that I talked about, young cancers, multiple generations. I think it's something you should strongly consider, talk to your healthcare provider about, something you very much consider. Genetic counselors can walk you through that. And the other question was age related. What age should I be thinking? For really, when I talk to patients, I say, when is this information going to affect you? That's definitely when you should think about actually pursuing it. So if your medical management recommendations would change when you're 25, because of that particular gene or some of the things we're thinking about, well, pursue that in your early 20s. Let's make sure that you're not dealing with that, because your medical management, some decisions need to be made, right? So that'd be a good time to make sure that you're incorporating that information.
Thank you. The next question is, there are some news stories about cancer incidence increasing among adults under the age of 50. Have you noticed an uptick in genetic counseling appointments for this patient population under the age of 50?
That's a great question. So that's the patient population that generally comes to see us. So I would say immediately, just related to that very important point, I wouldn't say that we saw a massive increase, just because that's generally the age range that's coming to us anyway, because of a young cancer diagnosis or that type of thing. Genetics is always something we think about. Now, the other question that wasn't quite asked, but I'll address it, is, are there more genetic mutations because of that we're noticing because of this early age of onset that's growing? And I'll actually say that no is the answer to that. You know, population statistics and the guideposts that I mentioned have stayed relatively the same over the years. What I will say is there's a lot of other reasons we think that early onset cancers are happening that may not always be genetics impactful. It's not just because, oh, all these folks now have genetic mutations. We think there's a lot of external things probably happening, some of which we can define, some of which we can't. That's probably impacting some of those incidences.
Great, thank you. And then we have a duplicate question. So this is definitely a hot topic. Do I need a physician's referral for genetic counseling or to get started?
Great question. So the short answer is no. And I say that because we routinely have folks that will find us one way or another, or their healthcare provider will say, oh, wait, I think UT Southwestern has cancer genetic services. And they can call us and you can get an appointment. The only time that I ever think about a referral being needed, there are some HMO plans that might need a primary care referral in order for the testing to then be funded by the HMO eventually. So we talk to patients about that. We give them a heads up at the time of scheduling, but just to get an appointment with us, no, you can self-refer. Healthcare provider can refer, whatever works.
Awesome. And so if you do get that referral and you're scheduled with a genetic counselor, if it's not a telehealth appointment, where do these appointments take place?
Great question. So you see that beautiful building in our background. That is our Dallas campus. So our Cancer Center outpatient building of the Simmons Cancer Center is where genetics lives. We live on the 7th floor of that building in our suite. That's also where the Genetic Cancer Prevention Clinic takes place at this time, in person in Dallas at this time. We are hopeful to expand beyond that in the future. And then we also have an in-person practice at Fort Worth at the Moncrief Cancer Institute at our Simmons Cancer Center in Fort Worth. So we can see folks there. Hopefully we'll be at Redbird in the coming year at our site there. But then otherwise we can serve folks via telehealth wherever they may be in the state.
Fantastic. And then this next question is, my genetic counselor ordered a WES panel. Would that show cancer genes? Can you talk to what that panel would include?
So WES, I'm assuming you're talking about whole exome sequencing, which that essentially means that's kind of bigger than the panel test that I was talking about. Panel testing, when I say that verbiage, is looking at a bunch of specific genes, right? So they're known genes, and they're known coding areas. Whole exome sequencing is like a genomic test looking at all the coding areas, and that's very much outside of just the cancer space. That's looking at all the coding areas of the genetic code. In the cancer space, not something we routinely order for inherited testing. We may get there, but at this point, not a super routine to do that. So always happy to answer any other personal questions if folks have that at a later time. But it would likely include some cancer genes. It would just kind of depend on what was happening. So, but that's at least the difference between the test of whole exome versus panel testing.
Great. Okay. And then the last question I see, so we'll do one more call out to get those final questions submitted here. But could you share the telephone number again? And I'd be happy to put that in the chat for everyone. What's the best number if somebody wants to call and try to schedule an appointment?
Yeah, if you could put it in the chat, or I can do it later too. It's 214-645-2563. That actually takes you to our department, to our patient intake team. We do have a unique patient intake team just because we have complexities with all the places we serve, UT Southwestern and otherwise. And so the great thing though is you can get right to our team. We can get you scheduled, and it's a very easy process.
Well, fantastic. Well, it looks like we have thoroughly covered all the questions as of now. You also have some kudos in the chat, Sarah. Thank you so much for all of the information. You made it very easy to understand, which is absolutely true. And then one last question, is that the same numbers for referring providers as well? Would that be the same number?
Yeah, I think you could use that number for anyone that's trying to contact us for any reason. Absolutely.
We will get you to the right spot. Perfect. Okay. Again, lots of thank you, Sarah. I extend the same to you. Really appreciate you taking the time to share such important information on this really special week where it's really important for us to stop and acknowledge what we know and what more we hope to know in the near future.
Absolutely. Well, thank you for having me. I've so enjoyed this. I love speaking on this topic, and really welcome to take care of anyone in our practice. We are here to serve. So we're happy to see and speak to anyone.
Absolutely. Well, thank you, and thank you to all who joined us for your lunch hour. We really appreciate you spending some time with us. And please continue to look for these lunch and learns. We hope to have these on a regular basis in the next several months. So stay tuned.